Yo, 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 Matt Legends. How are you today on this Monday? I've decided to title my segment now. I've been running consistently now for a few weeks, so it's going to be now the Monday MAT Musings. Anyone who's maybe followed some of my other stuff might know I had an opinion highway musings previously, but that was in the car, and I don't advocate people live broadcasting whilst in the car. All right, what we're going to talk about today is ACLs. This is a topic that we get a lot of requests from the MAT community and our MAT users as to best handle, because I guess it's probably the biggest and most complicated injury that a lot of us see. It's certainly one of the ones that, for want of a better word, is probably one of the sexier injuries, in the sense that it's the one that, costs a lot of money. Like, the big athletes are doing these big injuries, and they're the ones that get a lot of headlines and a lot of publicity. So it's one that we see a lot in our clinic. Obviously, we've kind of built a bit of a reputation as dealing with these type of injuries, particularly given our use of a lot of technology and equipment. And it's one that, a lot of people that we work with as part of that obviously see. And people want to do really well when they're managing these injuries, because for a lot of people, it's a case of we're dealing with people's potentially sporting careers. We're dealing with the things that they want to be able to do. There's a lot of fear and anxiety around these injuries making full returns. So we want to do really well with these complaints. Now, one of the most important times is obviously during that early stage rehabilitation. And the reason why I wanted to talk about this is because I saw a patient only this week. I actually even posted a video up of some of the things that we did during our first consultation. This is a patient that I had seen previously for other complaints, and unfortunately they had injured their ACL, just in a fairly innocuous incident, actually playing basketball with their child, and unfortunately fell over their child and ended up damaging their knee. A fairly athletic individual and a little bit older. So actually our initial plan was to try and manage this person conservatively without going in for surgery. Because we know from the research that sometimes not everyone needs to go in for surgery for these injuries. It depends on what they're trying to return to. It depends on what their goals are. And we shouldn't just be shoving everyone straight in for surgery when these ACL injuries occur. Unfortunately for her, one of her big things is that she loves to box, and she's already quite hypermobile. And even though she was doing a great job in terms of her rehab, it just wasn't quite coping, and she wasn't quite getting to where she wanted to be. So after some consultation with some other orthopedic surgeons, she ended up going in for the surgery, right? So look, these things happen. That's fine. Not a problem with that. What ended up happening, though, for this individual was that she had the surgery, and then under the guidance of the surgeon and some of the initial team that were looking after her, she was put in a brace for an extended period of time, almost, up to 6 weeks, which was pretty hefty, right? So I've seen her then now in our first session at the 7-week mark. She's literally only just started coming out of the brace, and she's only just starting to get around and returning to work. Now, here's the big issue with that, right? It's probably set her back at least a few weeks in terms of her rehab. Now, the reason for that is that overprotection of that graft can lead to its own issues. We know initially in that first phase, one of the most important things that we can do is obviously look after the graft itself. Okay, it is a surgery that has occurred. There is, a new tendon that has been placed in there that is trying to adapt, and become, I guess, a new ligament. And during that phase, it can be weakened and it can be at risk. But sometimes as well, I think during that protective process, sometimes people can be too conservative too. So what's ended up happening for her, unfortunately, and look, lucky we did so much work in the lead up to it to really build her strength, build her capacity as high as it possibly can, because coming out the back of it, she's been left really weakened, so much so that she's actually lost about 6 centimeters of her thigh girth when we measured that. So measuring her thigh girth, we measure from superior to the superior pole of the patella, about 15 centimeters or so on both sides, and measuring that, her ACL reconstructed side, 6 centimeters less, so a lot less strength through there. Okay, she's also reducing her flexibility. So we know initially one of the important things that needs to happen is obviously that she has, or any ACL reconstructed patient has, adequate flexibility in through the knee, and particularly one of our first goals is to try and get that full extension of the knee. We want to try and get that so that that is able to fully extend. Really important just for general walking and general gait and ambulation. If you can't fully extend your knee, you can't get adequate toe off. Your hips are going to become pretty tight and pretty wound up. So that's obviously really important. And then try to get adequate flexion. Usually the initial goal is somewhere around that kind of 110 degrees of flexion is one of the first things. So she's quite limited in that. She's still got a little ways to go in that respect, even though she was quite hypermobile in general, particularly in that knee extension. So that's been restricted in particular because she's been in the brace for so long. So one of those things that we need to be really careful with there. Then obviously the next thing is her strength, right? It's been totally reduced. We did some testing. We use a lot of strength testing equipment here as well, the ACL system, to be able to test out her strength. And she was about a 75% difference from side to side, which is pretty massive. She'll need to be at least within 10%, by the end of her rehab journey, but likely it's going to be even stronger than that, as we continue to progress. So she's still a while off there as well. The other thing was, of course, we took her to the MAT, right, and we were able to perform some tests on the MAT as well. And some of our go-tos in particular, I think, that are really nice for those initial ACL rehab injuries and those initial ACL reconstruction, rehab journeys is particularly our weight-bearing lunge test. So the great thing about the weight-bearing lunge test is it really does give us a good general measure of flexibility, even though it's designed mostly to assess the foot and ankle dorsiflexion range of motion. We can also see kind of how comfortable she is at loading through that knee as well, particularly in a pretty safe and controlled environment. So it's particularly useful in that respect. Now, she was pushing at about 2 centimeters on her ACL reconstructed side compared to about 11 centimeters on her other side there. So a pretty massive difference. Now, a lot of this is obviously not so much joint restriction, tissue restriction. It's more guarding and protection in through that, but it gives us a good measure to measure how she's progressing in terms of her developing confidence, I guess, in being able to weight bear and put more load through that knee as we go. The other thing that we then did as well is we did star excursion balance test, and particularly focused on the anterior and just the medial reaches to begin with in this session. We'll cover more of those as we continue to progress. But the good thing about those ones in particular is it really gives us a look at how comfortable, once again, she is at being able to flex through the knee. And interestingly, if you have a look at the video that I posted up in regards to that ACL reconstruction, you'll notice a huge difference from side to side in terms of the way in which she gets the job done. Her actual measurements were only around about a 4 or 5 centimeter difference, I think, on the anterior reach, maybe slightly more on the medial reach, but the way in which she got it done was totally different. So it's one where we can really start to use those measurements to not only assess, once again, the actual range of motion in which she's able to perform those movements, but the comfortability at which she's performing them as well. So a really important one to be able to look at. So we really love the weight-bearing lunge test, really love the star excursion balance test, particularly once people are comfortable enough to kind of stand on one limb. They are weight-bearing a little bit through there to then use those measures to assess how someone is progressing, because we often find that they progress relatively quickly as well. As soon as someone starts working on these movements, starts working on their flexibility, starts getting a bit more flexion and movement in through the knee, starts working on their balance, their control, starts developing their strength. These things are all going to pick up quite a lot. So it's a great way to engage the patient or client, particularly during that rehab journey, to make sure they can see how they're improving and how things are actually being affected there. So really good ones. So coming back to, I guess, that plan, so that initial phase, it's probably that, you know, first 6 weeks of management of your ACL rehab clients, maybe your rehab patients. If you are dealing with ACL injuries and ACL reconstructions, I think one of the takeaways here is you've got to work with the individual. Don't just stuff everyone into a knee brace or a knee support that's going to lock them in their range of motion, if they can tolerate being able to start working without that, right? So it's something that often you might need to do for that initial period, maybe that first 1 or 2 weeks, but certainly beyond that, we really want to be working with people to try and coax them out of that, as long as it's safe to do so. Maybe there might be some individuals in which, look, it's worth the risk in terms of being able to protect them more. Maybe for whatever reason they're a higher risk case of a re-injury or something like that. Then maybe you would brace that individual for a little bit longer. But otherwise, if you don't have to, you want to be pushing people out of that brace, getting them moving, getting them weight bearing, getting them doing as much as they possibly can, as early as they possibly can, in a safe and controlled way, because that's the thing that's going to actually mean better outcomes at the end. But when we go to the research, we look at individuals who've been braced for longer periods of time and those who even were totally out of a brace. Often what we find is the ACL integrity, exactly the same, but often the cases or the, I guess, the rate at which individuals still have knee pain are often more in those individuals who've been braced for longer. And I think often a big part of that is because they're the ones that end up having less range of motion, often less strength, maybe less balance and control, and that protective environment probably reinforces some of those nocebos, as we like to call them, right? Those things that would generate maybe more fear and anxiety around their knee because it's been so protective. You know, they don't want to use it quite as much. So there's some tips from us here at MAT. As I said, often the ACL is the thing that people want to talk about the most because it is such a well-researched injury in the way in which we can help people. And it's also really important to make sure that we minimise any risk of reoccurrence of those injuries as best we possibly can. So if you've got any other ways in which you like to manage those ACL injuries, let me know in the comments there. I'd be interested in if you had any kind of thoughts on maybe, you know, what are some of the best flexibility exercises to get that flexion or extension back. Do you do any interesting or different strength exercises? Are you one of those ones who are like, we only do closed kinetic chain exercises, or do you do some open chain ones as well? I'd be interested to hear some of your controversy there if you've got any of that. So I'll leave you there. That's my Monday MAT musing about early stage ACL intervention for Monday, and I'll check in with you next Monday. Of course, though, I can't leave without mentioning we have launched our MAT online courses for 2019. So MAT Online Level 1 as well as our MAT Online Level 2, only available online as well, the MAT Online Level 2 course. So if you are interested in jumping on board with that, all you have to do is go to matassessment.com/MAT Online Level 1, and you'll be able to find all that. I'll include that there in the comments as well, so that you can check that out. So jump on board. The enrollment's closed at the end of the week, so very, very limited. It's only going to be around for a short amount of time, and it's the only time we're going to be running it in 2019. So if you don't jump on board, you're going to have to wait until 2020. Anyway, we'll leave it there. Speak to you guys next week.